Uh, right. And so it's basically a little package with genetic material. And it's so small that you cannot see it under a light microscope. You have to have an electron microscope to see it. So there's this little package of genetic material with a coating. And that coating contains something called glycoproteins that, so when somebody sneezes and this virus transmits then through the air to your nose, it'll connect to the cells and penetrate them, and then it'll build its own genetic code into your cell's code. So basically a virus cannot replicate by itself. It needs to replicate inside of you. It needs your living cells to replicate. And so the coronavirus is basically, the word corona comes from the spikes that you can see. If you look under the electron microscope, you can see this spikes all around it. And it's basically the common cold virus that's been around for a long time. But we do have reason to believe that this one was modified to be more aggressive, and there's more evidence coming out that it's in fact a modified virus, modified in the lab, maybe as a biological weapon. We don't know, and we don't know how it got out. It could have been by accident or whatever, but yeah. So that's basically the definition of a virus, and you get different kinds of viruses. You get RNA viruses and DNA. And this one is an RNA virus. So, and it's interesting just on that subject. When you have like a cold sore, or you've got chicken pox, all those are also viruses. And this particular RNA viruses are very. It's always a bad idea to give somebody cortisone when they have an outbreak of cold sore viruses on their face, because you'll make those cold sore viruses spread all over the face if you give them cortisone. You never give cortisone in the active phase when the virus is replicating, because you will help the virus. And that's sort of, we'll get into that, but that's one of the things to keep in mind of these RNA viruses.
And Harry, if you look at COVID, the different phases of COVID, can you explain maybe the different phases that we need to deal with?
Yeah, so it's very simple, and so basically there's a 5-day period, and it's very, if you go on the FLCCC website, you'll find a lot of information by Professor Merrick, and the whole group there, that and it's a beautiful scheme that you can look at. But for the first 5 days, the virus can just replicate. So the virus basically replicate without you actually knowing that it's there. Most of the cases of COVID that I have seen personally, the people got the virus from somebody that was asymptomatic. So they were at a meeting, or they met somebody, or they shook their hand, and the next day, that person phoned them and said, look, I came down sick today, and I went for a test and I got COVID. But the actual meeting with the person, that person had no symptoms. And that was most of the cases. I mean, I don't say that's the only case, but that's in my experience. So the most contagious day would be the day just before the symptoms start. And so I don't actually call that's actually the first phase, but I don't call that a phase, because I try to simplify things, and you don't experience that because you're asymptomatic. So I always say phase 1 is when you start getting sick. For the patient, that's phase 1, So phase 1 is from day 5, you start getting symptoms. And that lasts up to day 11. So basically, that's a 6 to 7 day period. And in that 6 to 7 days, the virus is now replicating inside of your body. It's causing disease. And the symptoms are body aching. That's very common. The muscles ache, the body ache. Some people get pain in the chest area. Headache, it's very common. And then, funny enough, nausea and even diarrhea can also be a prominent symptom. So those are all symptoms. It's a bit like a flu kind of picture, but with the nausea, diarrhea part, and so forth. I actually went through the whole disease myself, so I can tell from experience how it goes. So in that phase, that the patient will call phase 1, I'm getting sick, what's happening? You want to kill the virus. That's your goal. You want to kill as much virus as possible, as quickly as possible, to minimize your risk to go into what we call phase 2. And phase 2 will be from day 6, 7 onwards. Say day 7, for instance, 6 or 7. And that's when you get this immune reaction that attacks your lungs and even your brain. By that time, the virus is already sort of dead, and you're dealing with a lot of viral debris, but your immune system is now overreacting, and it's causing the cytokine storm, that whole immune reaction. And that's very bad for your body, because that can actually cause fibrosis, which is like scarring on the lungs and in the brain. And at that junction, the rules change immediately. So if somebody, I actually didn't go through that, because I really killed the virus nicely in the first 6, 7 days. It was my hobby to kill the virus in those days. So I didn't actually go through the cytokine storm at all. But I had some family members that went through that. And they would suddenly, day 6, day 7, suddenly they have deteriorate. The lungs particularly are the target organ. And they need cortisone immediately in a good high dose, because you want to now stop this whole immune reaction. You want to stop the fibrosis. You don't want them to get a lot of scarring and damage, and you want to keep them out of the hospital. So that'll be phase 2. And that's where there's 3 things that are particularly important. That'll be the cortisone. And it's interesting, if you look on the FLCCC website, there's many different kinds of cortisone, and there was up to a 20-fold difference in the rate in which different cortisones would save lives. So it's important to use the most effective one. And for the lung phase, it's called Medrol. And that's the one we use, Medrol. I usually give between 32 and 48 milligrams of Medrol twice a day. In that phase, I give a blood thinner, because most people die from a blood clot. So I usually give something like Xarelto. This is now for an outpatient, that's at home. And I give the ivermectin, of course. So those are the 3 main things. There are other things, but those are the 3 essentials. And you can quickly, if you do that promptly, you can turn the disease very quickly. Within a day or 2, the saturation goes back up and they feel better, So that'll be the second phase. And then the third, what I call the third phase, is called long COVID. And that's a lot of people don't realize this. And I went through that to a certain degree, where I had a very light phase 1 because I killed the virus nicely. I didn't have much of phase 2 at all. But I just, after the second week and the third week, I just felt my energy is not coming up. I don't have appetite. I'm not getting rid of this completely. And there's a different protocol we use there. We use a different kind of cortisone called prednisone. And that's, again, if you look on the FLCCC website, it's all the long COVID protocol is outlined there. But there I use prednisone 40 milligrams daily for a few days, and then taper it down slowly. And that rapidly, within the 3rd day or the 4th day of the prednisone during the long COVID, your taste returns, your appetite returns, and you feel good energy again. So there's actually these 3 phases that the patient experience that you have to know about. If I want to just get back to phase 1, to kill the virus. I mean, that's where you want to really climb in and do something. And we have a list there. The ivermectin, of course, we use that at a double dose. So I go for 0.4 milligram per kilogram daily. for at least 5 days. I can go up to 2 weeks. It's very safe. That helps to kill virus. It helps it's anti-inflammatory. It's got a lot of benefits. I use the Lipo-C, the quercetin, melatonin, everything on that list, vitamin D. I also like the MZN, which is a essential oil mix that's mixed with sulfur-containing compounds. There's a lot of interesting research coming out on the ability of a virus to penetrate your cells. If you have a lot of sulfur-containing compounds on the cell surface, the virus have a rough time getting into your cells. And that'll be supplements that I really like, MSM and NAC, which is common supplements you can find anywhere. It helps that sulfur layer, and the MZN does the same. But the most effective way to kill the virus is intravenous vitamin C. That's tremendous. So when I came down with the symptoms, I immediately asked my nurse to give me a vitamin C drip. I just took a 25-gram drip, a very small drip, and about half an hour after the drip, I felt something just lift, just immediately. My wife came down a little bit later, a few days later, and I gave her 100 grams of vitamin C. So I gave her 25 grams, another 25 grams, another 25 grams, just sitting there, and the fourth drip, halfway through, now she's feeling better. So most people will actually feel better during phase 1 immediately with vitamin C IV. The intravenous vitamin C just works way better than any oral vitamin C can possibly do. It's just getting somebody to give you that, that's, and it's always tricky getting COVID positive people in the active phase into a clinic. It's difficult. You have to use precautions so you don't expose the other people in the clinic to the COVID.
So I just want to ask a question here. Why blood clots?
I think it's part of the whole immune reaction that we have there. It activates the clotting cascade, but it's extremely common. It's absolutely. People are concerned about thinning the blood too much. I'm not concerned about it at all. I mean, they die. Nobody dies from bleeding in COVID. They die from a clot. Ivermectin has a bit of a blood thinning effect. You can use ivermectin with blood thinner, with other blood thinners. I mean, on the FLCCC protocol, Professor Merrick uses the ivermectin with injectable low-dose heparin in his in-hospital patients. But if somebody's like on another blood thinner, like warfarin, for instance, you can still use ivermectin. You just have to adjust the dose of the warfarin. It's very simple. The doctor just checks the INR and adjusts the dose. But all of my patients go on Xarelto, 10 milligram, plus the ivermectin double dose. And I've never had a blood clot so far. But I had people that we know that died from blood clots, several. So that's the thing you have to immediately. It's very, very important. And of course, good hydration as well. Drinking enough water will also prevent blood clots.
Question that in the chat box on ivermectin, just the difference between the one for human consumption and the one for animals. Is there a difference? Can we use both? What do you suggest?
Okay, so ivermectin is a very interesting compound. It was discovered about 30 years ago. It has been used in 250 million human beings before this pandemic started. So it's really not an animal medicine at all. It was discovered in Japan by a Japanese researcher that worked with an American, and it was discovered in a soil sample. It's actually a compound. It's a naturally occurring compound that the soil bacteria makes. And that's how a lot of antibiotics work. We like penicillin. It's exactly the same thing. Nobody made penicillin. Penicillin was discovered. One germ fighting another germ, and that's ivermectin. And so initially, ivermectin was used for parasites and for all kinds of things. It's FDA. The Federal Drug Administration in the United States okayed ivermectin for human use years ago already for the treatment of head lice in school kids. So whenever they had an outbreak of head lice in an American school, the FDA would recommend giving ivermectin to kill all the head lice. It was used in Africa and other places where there's a lot of parasites. All kinds of parasites were killed by it, and so forth. So the human one and the animal one is the same compound, you know. The only difference is that if you buy an ivermectin that was made for animal use, it's usually an injectable, and the injectable contains a lot of other ingredients. And you could be maybe allergic or sensitive to some of the extra ingredients, because this compound was made to inject under the skin into a cow, and they have like carriers and other chemicals that go with it. So I mean, if you're in an emergency and you don't have any ivermectin, I would take the animal one. I would do it myself, but it's preferable to use the pure human one, because there's no other. It's pure. Your chances for any reaction is much less. I asked my pharmacist right in the beginning to do a search on ivermectin, because I mean, obviously we want to know everything about ivermectin we can. And he came back to me and said it's definitely safer than Panado. In fact, this Panado is way more dangerous than ivermectin. And interesting enough, Panado is one of the #1 killers in the world. It kills more people than any other drugs, Panado, which is paracetamol. So ivermectin is way. So somebody gets excited about ivermectin, that they must never consider taking 1 Panado per week. It's way too dangerous. I mean, that's living on the edge, you know.
Agree. And ivermectin as a preventative measure, how do you take it from a preventative perspective?
Okay, so the current recommendation is that you take 1 dose. You have to adjust the dose according to your weight. It's 0.2 milligram per kilogram. And then you take 1 dose right away, you take a second dose 48 hours later, and then you take 1 dose weekly. That's the current recommendation. If I get someone that's exposed to COVID, like they got a contact and not sure, I tell them, well, take it daily for a few days. You know, it's we've had patients that actually, I mean, we just observed this, but there was one patient I know that took 1 daily for 3 months.
Sure.
And she was fine, actually. So, but usually, if you get sick, if you go on the FLCCC website, you'll see that if you get COVID, we can double the dose to 0.4 milligram per kilo for a minimum of 5 days. If somebody's admitted into the hospital, like in Professor Merrick's hospital in Virginia, they give 0.6 milligram, which is 3 capsules daily while in the hospital. With the blood thinner, with everything else, you know.
And then I just want to ask, someone once mentioned to me that ivermectin is an immune suppressant. So what's your thoughts about that?
No, I don't see that at all. Ivermectin actually, it's an antimicrobial agent. It does have anti-inflammatory effect, but that's a good effect because it sort of guides the immune system not to overreact. But it's definitely not an immune suppressant like you would give a chemo or something like that. That doesn't happen at all. I mean, even cortisone can be seen as an immune suppressant, but cortisone can also be seen as an immune stimulant because it depends on the dose and how you use it. But ivermectin is definitely not your immune system actually will react very well when you take ivermectin.
So my question just here as well, just as a rule of thumb, what would you say for people, because ivermectin is the big name around and everyone is like, do you have ivermectin? And I know people just put like little bottles of ivermectin in the post boxes of other people. What's the rule of thumb for everyone to stay safe when it comes to ivermectin? What would you advise?
Okay, so there's a lot of data available, a lot of research. I mean, if it was used by 250 million people. And there's enough data available. I mean, it's one of the most used drugs ever. So telling me there's not enough research is nonsense. And the adverse reaction is extremely, extremely low. It's much lower than aspirin. It's much lower than paracetamol. It's much lower than many common drugs that people don't think twice about using. So it has one of the best safety profiles of any prescription medicine that I know of. I mean, there's side effects possible with anything. You can be allergic to anything. I have used a lot of ivermectin in the last 2 months on many people, and I've had one or two that maybe had an allergic reaction or some kind of a rash or something. Sometimes I think what happens is that you kill a lot of parasites, and somebody gets more what we call a Herxheimer reaction, where the death of the parasites cause a reaction. So in that case, we give a little bit of an antihistamine and so forth, and it goes away, and they can keep taking the ivermectin because the parasite load is now lower, and they're good, you know. And it's interesting that the anti-cancer research coming out on ivermectin now is very fascinating. It even has an effect on cancer stem cells. So it's a very interesting compound.
And
in fact, the research showing the antiviral effect of ivermectin is already 10 years old.
It's fantastic. A question from somebody: asthma and ivermectin, there's no negative effect on
no problem. No problem.
Somebody's just asking in the chat room, I thought that's quite good. It says, do I understand correctly, if you've got a running nose or sinuses, is there any medicine you might drink to dry it up, or is it better not to dry that up when you've got COVID? So when you tested positive in phase 1, I would imagine.
Look, my experience of that is if you use the antivirals to kill the virus, it works so effectively that, you know, it's like in my case, this was maybe the mildest flu I ever had. And my nose actually, I had to blow my nose, but it never blocked. And my nose blocked easily in the past. I mean, that was the thing of when I got the flu, my nose was the problem. And in this case, it was really a tame virus. But I mean, I took the MZN, I took the thyme oil, I took the zinc, I took everything, the IV vitamin C, and it just killed this virus dead. I mean, it's amazing how quickly it left me.
Now, Harry, I just want to ask you to shift a little bit gears from ivermectin to cytokine storm. Just to explain that a little bit to us, because there's a lot of talk about it, but we really don't know exactly what it is and what happens in the body and in which of the phases that would then actually be presenting.
Yeah, so the cytokine storm is basically what I call phase 2. That's about day 6, day 7. So, and that happens when, I mean, the chances are much higher of getting a cytokine storm if you didn't do a good job in phase 1. So if you have, the more virus replicates in your body, the more the burden on your immune system, the more likely you're going to get that cytokine storm. So like in my case, I didn't get it at all, but I had family members that actually got it. And the cytokine storm is basically now, the virus is virtually gone. It's basically dead, but your immune system is now going crazy. And it's overreacting, and all these different messengers and chemical compounds just cause a huge amount of inflammation. And an inflammation is like an aftermath of the infection, and that targets the lungs, it targets the brain and everything, you know. So that's basically the cytokine storm, and that's where the cortisone is needed. That's where the Medrol is needed, and depending on how bad the cytokine storm, you can go really high. You can barely overdose on that Medrol. Like the intravenous form of Medrol is called Solumedrol, and Professor Merrick goes up to 500 milligrams of solumedrol in some cases in a hospital setting.
Is that then why day 10 is such an important day? Because if I start to look and read a little bit, then day 10, when it comes to the lungs and the introduction of different medications, is that a link then between?
Actually, to the patient, it'll be day 6 or 7, because the day 10, 11 is from the first contact with the virus, but you're not aware of the virus for the first 5 days. So if you ask the patient, when did you get sick, that could be up to 5 days after the first contact with the virus. So I would really start watching them very closely day 6. So the 6th day after the like I had a family member call me from another town. His son they had COVID, and the son was feeling really badly that evening, and I asked him carefully, when did it start, and it was about day 6 going on day 7, and he was struggling to get breath, and I clearly knew this is the start. This is now the cytokine storm. This is now phase 2 starting in this young man. And I told him to go to the pharmacy right away, and I gave him, he's a big guy, so I gave him 48 milligrams of Medrol twice a day. I gave him the Xarelto. I gave him 20 milligram, and I told him to double his ivermectin and to take the melatonin and all the other things. And I also told him to buy an oxygen saturation meter, at the pharmacy, so we can just check his oxygen saturation. And they didn't get back to me. A pharmacist called me. I got the prescription, and I didn't hear from them, and I went to bed. And I woke up the next morning, and this message was on the cell phone. His saturation is 70%. So I said, my goodness, that's hospitalized. I mean, that's, normally in Professor Merrick's protocol, you'll see if it goes under 94%, he's already worried. But in practice, if it goes under 90, that's when when it goes under 90, we're thinking hospital. Okay, if it's above 90, we can still go at home. That's sort of rough, But 70% is bad. But so I immediately called him, and he said, no, he's fine now. This morning his saturation up to 90%, and he's feeling a lot better. And that was after 1 dose of 48 milligrams of Medrol. So we just immediately gave it, and it worked quickly with the ivermectin and the blood thinner.
So, Harry, just a question here. Cortisone in phase 1, you've mentioned it, but if you can just go through it again, what's the effect of cortisone in phase 1? So
with RNA viruses, if you give them cortisone, they multiply like crazy. So it's like, and if you've ever seen this, if you have somebody with like eczema, and they get cold sores, and they put that cortisone cream on the cold sore, it'll spread all over their face. It's just terrible. The same thing with like chicken pox. If you have chicken pox and you give that patient cortisone cream or cortisone, that chicken pox will go crazy. And that's why Professor Merrick recommends not to use cortisone in the first 6 days or so. Rather concentrate on killing the virus, and only use the cortisone when you need to. So that there's 2 indications for cortisone. The one is the phase 2, to wear off the cytokine storm about day 6, 7. And the other would be the long COVID. So if you get that long COVID where that lack of appetite, lack of energy just lingers, and it's already week 2, week 3, then we give the prednisone. It's a different kind of cortisone tablet, and we taper that down over 7 to 10 days. I see Professor Merrick tapers it down over 15 days. But I did it myself, and it immediately, within a couple of days to the 3rd day, my appetite was back, and I was having energy again. By day 5, I was virtually over it,
So, I mean, I'm not sure how to verbalize the question, but you've got all these dead virus cells, I would assume, in your body. I'm not sure if it's a cell. How do you get rid of it? How do you get it out of the body?
Okay, that's a good point. And that's now that gets to the long-term immunity question, because you have different kinds of immune reactions against the virus. The one is called humoral, and that's your antibody response. But the other kind of immunity is called cellular immunity. That's called your T cell response. So you get cells called natural killer cells, or T cells, and their job is to find infected cells and kill them and get rid of them. And there's research coming out showing that even though your antibody levels might decline after a while, your T cells are able to maintain an immunity a lot longer against these coronaviruses, and it'll actually go and eat up those infected cells and remove them. So the T cell, the cellular immunity won't prevent you from getting sick, but it will prevent you from getting very sick. It will, because the T cell, the antibodies are great in the sense that it kills the virus when it lands on the surface of your mucous membrane, but the T cell will identify the cell that's been infected and eliminate it. And the interesting thing is that the T cells don't care about variants. It can distinguish out to 80% variant difference in variants. So if you ever had any of the variants, the T cells will recognize the other variants as well.
Sure.
So that's a good one. That is like, it gives me a great relief, because there's a huge debate about vaccines and stuff like that, which we will not cover tonight. But if your body can make and identify those things better than vaccines, that you can think a little bit through what to do. I just want to ask, in terms of supplements, what would you recommend then? Supplements post-COVID, supplements when you've got COVID, and then supplements
Long
haul. So pre-COVID, COVID, long haul.
Okay, so vitamin C, I like the liposomal formulation because we get way better absorption, penetration in the tissues. But vitamin C doesn't work by itself. You need to add lots of things called bioflavonoids. And that's where I like to add something called citrus bioflavonoids. The citrus bioflavonoids makes the vitamin C work a lot better, and also quercetin, which is a bioflavonoid. So vitamin C never works in isolation in nature. It always needs all these flavonoids, these compounds, to make it work. So you'll see on Professor Merrick's program, he emphasizes the importance of flavonoids, bioflavonoids, with the vitamin C. Then, so definitely lipo-C, quercetin, citrus bioflavonoids. That goes together. Then the next one would be zinc. So the zinc is important. The zinc accelerates tissue healing. It has direct antiviral effects. It competes with receptors for the virus and so forth. So the one I like is called zinc orotate, and I use about 60 milligrams a day. It penetrates very nicely. I always use a little bit of manganese with the zinc because those two elements go together. Then, of course, melatonin. And an interesting fact was that bats carry coronavirus without getting sick, and they have extremely high levels of melatonin. And so now when you use melatonin, there's various articles out, and the ideal dose is not clear. There's in Professor Merrick's writings, it goes up to 9 milligrams or so a day. There's other articles that come out with 25 to 50 milligrams twice a day, and in very sick people up to 200 milligrams twice a day of melatonin. So there's a lot of variance there. If you use melatonin for sleeping, then you'll notice that the lower dose makes you sleep better. The physiological dose of melatonin is 0.5 milligram. And at 0.5 milligram of melatonin, you'll sleep the best. So when you go up with the dose, like therapeutically, say to 9 milligrams of melatonin, you might sleep very intensely for like 2-3 hours and then wake up wide awake. And that's because you're overdosing, basically, physiologically. melatonin. So there might be, so what I like to do, and I'm using a lot of melatonin right now, even now post, I really like my melatonin at the moment. So I like to use a slow release 2 milligram melatonin tablet at bedtime, and then I have a liquid melatonin to just put me to sleep. And if I wake up at night, I would add another little bit of liquid melatonin. The liquid melatonin gets absorbed from the mouth floor, and it bypasses the liver, so it's very direct. But you have to sort of experiment as far as sleeping is concerned with the amount of melatonin that you can tolerate. If you go too high, you're going to have this intense sleep and then wake up. So you might want to just lower your dose then. But melatonin has a very powerful antioxidant effect throughout the body. Melatonin is anti-cancer. Melatonin is one of the most amazing molecules. We even use topical melatonin now to make hair grow back and after chemo and all kinds of stuff. So melatonin is a wonderful thing. It is strongly anti-corona. So that must be on your list. And then essential oils. I like thyme oil. I mean, I know Hiri likes essential oils. I like essential oils too. I mean, these oils are amazing. And thyme is my favorite for viral purposes. So thyme oil, you can actually take, if it's a good quality one, you can take it internally. It's a little bit strong, but an empty capsule might do the trick, you know, to get it in. But thyme contains thymol and thioanol, which is compounds that are extremely potent antiviral. And of course, the MZN product is basically a mixture of these essential oils with a lot of sulfur, and that helps both the barrier and it's very effective. I usually prescribe up to six teaspoons a day of MZN during the acute phase, and I'm seeing good results. People that take a lot of it early seems to kill the virus very nicely.
Harry, in terms of inflammation, what is the role of inflammation in the COVID period, and how do you get rid of the inflammation?
So the inflammation and the cytokine storm is basically the same thing, and okay. So basically that'll be what we call the phase 2, that day 6, 7. That's the inflammation. So if you're able to kill a lot of virus effectively in phase 1, you're going to have very little inflammation later on. That's basically the same thing.
Okay.
And then what about vitamin D?
I forgot. Vitamin D, so important. So I really like vitamin D. I use a lot of vitamin D. I personally use 20,000 units vitamin D daily for the last 5 years. You have to monitor people for the sensitivity to vitamin D. Some people can use more and some have to use less. I use the urine pH as my guide. So if somebody has I always aim for a urine pH between 6.2 and 6.6. If somebody's urine pH go acid, less than 6.2, maybe a 5 point something, I would push the vitamin D very high. If somebody's urine pH go too high, like more alkaline, more than 6.6, I would cut back on the vitamin D because I look at the end result, the effect of the vitamin D. The vitamin D blood level is not as helpful because it actually doesn't reflect the sensitivity to vitamin D.
Okay.
But vitamin D, I usually on my general list, most people are too acid. So I would on my general list use about 2,000 to 5,000 units of vitamin D, and I'll help most people that way, 90% of people. But there is the exceptions.
And then there's always a question: do you use it as a tablet or you use it as a capsule? Because I know sometimes it's liquid and sometimes it's like a pressed powder type of thing, or sometimes you just go and sit in the sun type of thing.
Yeah, all vitamin D that's available for sale is made by the same company worldwide. There's just one company that makes vitamin D worldwide. So it all comes from the same source. And I can't remember now. I think it's made from wool or something, like sheep's wool or something. I'm not sure. But it's basically a compound where they make the vitamin D3 from. It's all common source. So basically, if you take the powder, the oil, if you take the powder in a capsule, take it with a meal, you can absorb it. It's fat soluble, but you can absorb it still. But you have to monitor the effect of the vitamin D in the body. That's the big thing, and that's where the urine pH is so handy.
Harry, somebody is asking, COVID 12 months ago, still struggling with tiredness, etc. Any advice?
So that's long haul COVID. So you need a course of prednisone, which is the specific cortisone that Professor Merrick recommends for the long haul COVID. And if you go into the website, he has a whole, you type in long haul COVID and you'll find all the recommendations. But he recommends 40 milligrams of prednisone for 5 days. Well, he recommends it's 0. That's not mine. So 0.5 milligrams per kilo of prednisone for 5 days. Then 5 days of 0.25 milligram per kilo, and then 5 days of 0.125. So you taper it down over 2 weeks, 15 days. But I had the same thing, and immediately about day 3-4, I was a different person. Just amazing how the prednisone worked to get rid of those symptoms. And I would still use the other things like the melatonin, the lipo-C, and the zinc. And even nucleotides might be a good supplement to use, because nucleotides are involved in repairing tissue. You want to repair the lining in the body. A little bit of vitamin A. I always like vitamin A to repair the lining. About 25,000 units a day is a good idea.
Maybe just another question, heart palpitations. Somebody believes they've got heart palpitations after COVID, so long haul effect. Do you think that's possible?
Surely it could be possible. We know there's a huge problem right now with the myocarditis and the immunization, where there's, especially in young men, where they get myocarditis, which is a heart inflammation due to the actual vaccination. And that can lead to heart failure later in life. So yeah, but I mean, it could be that you already had an underlying problem and now the COVID just worsened it. It'll be a good idea to have your heart checked out, make sure that your arteries are open. That's the first step. So that you've got good blood flow, there's no inflammation around the heart. And then you need to get the correct minerals to keep the rhythm of the heart. Potassium is very important. We usually use potassium orotate. And then the best food for the rhythm of the heart is asparagus. Asparagus contains a particular mineral that helps to keep the rhythm in the heart.
Harry, I want to ask you about children and COVID, and especially young ones. We've got a friend now, and her 2-year-old was tested positive. So the question is, quo vadis with little kids, because they can't say that, how they feel, etc., etc., etc.
The good thing is that children usually get it very light. They mostly get it asymptomatically, and there's very few kids that ends up in hospital with COVID. It's like, and one of the reasons for that would be that in a small child, you have your Thymus Gland, which is a gland situated behind your breastbone that's very well developed. And the Thymus Gland makes something called thymosin alpha-1, TA1. And there's a lot of studies that was done, even in China in the early days of the COVID, that TA1 or thymosin alpha-1 really helps against this virus. It has an amazing effect. They have studies done in the hospitals there where they injected TA1 and the people just came through with bad cases. But a child has a very high level of TA1 because they have a huge, well-developed thymus gland, and that's maybe why they get it very lightly. There's very few children have a problem with this disease. We at the moment we don't recommend giving ivermectin if they're less than 15 kilos in weight. That's got to do with the blood-brain barriers development and so forth. It's probably safe even a bit younger, but we'll stick with the guidelines.
Yeah, well, that's a good one. Let me just have a look. Heinrich, anything?
Question again: gut flora, alkaline diet, those type of things.
Yes. So you I mean, if you have a high level of healthy flora in the gut, then you're going to have a high level of non-specific antibodies. So what we call IgA antibodies. So that's one of the reasons when you take antibiotic, and why we don't routinely give antibiotic with normal antibiotics with COVID. The antibiotic will kill a lot of good germs in your gut, and it'll lower your IgA level, making you more susceptible, okay, to the virus. So when I work on gut issues, I like to use a prebiotic as well as a probiotic. So the prebiotic would be the food that the germs like to eat. And there I use a product called XOS, xylo-oligosaccharides, that has been shown to increase the amount of bifidobacteriums in the gut. And your whole diet really is going to work together to maintain a healthy gut flora. If you're going to eat junk food, if you're going to eat stuff that's got a lot of chemicals and preservatives, you're going to kill your good germs that way, whereas if you eat this nice Mediterranean diet, you're going to have a lot of good vegetables, and you've got a lot of olive oil, all of those things, and all of those are beneficial. You're basically feeding those good germs, and they're flourishing. And that's, people take a probiotic and think they're fine. A lot of times those probiotics do nothing, because the germ don't want to live there. So it's not hospitable to the germs. So.
Okay.
Gary, just a question: is ivermectin better taken on an empty stomach or with food?
Right now, the recommendation is with a meal.
Okay.
Because the fat in the meal helps the absorption, because it stimulates gall production and so forth. And so I just take it with a meal.
Okay. And would cortisone help with the loss of taste and smell 1 year on?
Immediately. So, well, yeah, I've never had 1 year on yet. So I don't have experience, but all the cases that had the long haul, it was like weeks and weeks and weeks later. And within the third day of the prednisone, taste came back every time so far.
Okay. And then for a person above 60 years of age, is an oxygen saturation of 94 okay?
Yeah, the 94 is sort of the cutoff point. You have to understand, you get a lot of false readings, because if your hands are cold, you're not going to get an accurate reading. So I always tell people, make sure when you do the reading that your hands are warm. At least we get a proper reading, But look, if you the big thing in COVID to check the oxygen saturation is after day 6. So after day 6, if you're getting tightness in your chest, check the saturation. And the official guideline is less than 94. You've got a problem. We need to do something. And as far in my experience, if it goes less than 90, I send them to the hospital. I'll maybe try for 1 day, at home. But if I've maybe an oxygen cylinder there, I can help them with some oxygen for 1 day. But you have to get it above 90. But if you do the proper protocol, it quickly goes above 90 again.
Fantastic. And then just one question here. Someone said they are allergic to citrus. So how do they get vitamin C in?
Well, you get vitamin C from many other fruits than citrus. You can get it from guava. You can get it from many other fruits. Fruits have vitamin C. Yeah, and the vitamin. I mean, the bioflavonoids. Like if you can't take the citrus bioflavonoids, just go for the quercetin. There's other bioflavonoids out there. Like buckwheat, for instance, is a grain. That's not actually, it's called buckwheat, but it's in the rhubarb family. It's not a wheat, but it's very high in rutin and quercetin and other flavonoids. So if you do a little bit of research on the internet, you'll find a lot of sources of bioflavonoids and rutin and quercetin. It's in foods all around us. You want to eat a large variety of foods. You don't want to ever have a mono diet. Animals can have a mono diet because they're more simplistic, but a human being needs a very wide range of foods and variety to stay healthy.
Heinrich, we basically on an hour now. We can sit here for another hour. I want to quickly drop into the chat box just links to Dr. Lindeque's website. Also a link to Dr. Paul Murray's chat on the different phases of COVID as well. And then obviously I'm going to challenge all of you on the Mandelbrot set, because that is, if you understand how chaos looks like from a mathematical perspective, you also know how to bring stability and order back to that. So that's our challenge as patients, is to bring back the calm and to bring back stability, and in the way that we think, in the way that we approach things like that. So you can have a chat still to Harry, and I'm going to put the links in.
Harry, my question, I'm sitting thinking, what is the most important thing preventative? Is it ivermectin or is there something else that you would suggest?
I would put ivermectin as number one, but I will definitely look at the vitamin A, and even cod liver oil, which is a good source of vitamin A. Vitamin A always strengthens your mucous membranes. And then look at the gut flora. Get that gut flora strong, and you have lots of IgA antibodies. So if you have a good, strong gut flora, by taking maybe a prebiotic like XOS, take vitamin A, you take ivermectin, I think that's about that's up there for me.
Something completely different. We discussed it with somebody else the other day. COVID and the brain, COVID and depression. Any thoughts or comments on that?
Yes, I mean, all of these patients go through depression, with COVID. It's very interesting, and it actually works on some receptors in the brain, and it's also part of that brain attack on the brain inflammation. And I see Professor Merrick recommends an antidepressant called Luvox, actually therapeutically to protect the brain during the phase 2. And we do prescribe it. And actually, I found you need a very low dose. Some people are sensitive to the antidepressant. They get they don't feel it well on it always, but you can go very low on the dose. So his recommended dose is 50 milligrams twice a day. But I've diluted it down to 25 milligrams twice a day, even half of that. And just to lift them out of that, because it's interesting when you observe a patient going through COVID. I mean, maybe because you feel so bad, you get depressed. It's like, but it's also actually a direct attack on the brain causing it. And the Luvox is what's recommended to help that.
So would you say that there's a connection, that it's a gut-brain connection, something like that? Or is it
this is a direct, it's part of the Cytokine Storm thing that works on the brain. So the same fibrosis that you can get, that's why it's so important. You can actually get tiny blood clots in the brain. You can get fibrosis in the brain from the phase 2. That's why it's so crucial to use the cortisone immediately. You want to get fibrosis in your brain. I mean, that's ridiculous, So day 6, if you find it going into the lung thing, the same stuff that we use for the lung will protect your brain. You just might want to add the Luvox antidepressant, low dose, 25 milligrams twice a day. It's a good idea. It blocks the receptor.
So Harry, what you say is that phase 1, what we as patients has to do is get that viral load down, get it sorted, get an understanding, use ivermectin for it, use antivirals for it, build up the immune system. That would be the focus, is to get it under control there, so that we cannot move over into that phase 2.
Yes, that'll be the absolute best. And that's with doubling the ivermectin, using the thyme oil, using the MZN, and maybe using IV vitamin C works the best.
And then phase 2, that's basically where the body is just reacting to all these, I want to say, viral debris inside the body. And it causes this tremendous inflammation that's called the cytokine storm.
Yes.
And And now we need to deal with that, and to prepare the body for that, things that that's where you doctors are coming in and giving all that hardcore stuff for us. And that's the point where we need to stay out of hospital.
Yes.
So that would be food as well. Stay away from food that's causing inflammation, staying away from sugars, stuff like that.
Usually people in that phase don't want to eat. The appetite's very suppressed. You have to force them to eat.
So ivermectin in phase 2, when that debris is there, do we continue with that?
Yes, that's very important to continue the ivermectin, because ivermectin helps against the blood clotting. It helps against the actual cytokine storm, the inflammation part. So it has an important role to play. The 3 most important things to take is ivermectin, blood thinner, and cortisone. Those 3. And then you can add all the other stuff onto it, like the melatonin, the bioflavonoids, the zinc, and all those. But the core is those 3 things in phase 2. Using it early and aggressively. The right kind, the Medrol, would be the best kind for the lungs, and use enough. I see a lot of underdosing happening, where people give half the dose they should have given, and the guy ends up in hospital. And if I just gave the full dose with confidence, then the guy would have been better the next day.
Okay. And then the last phase, that is long haul, and that is where we start to ease out of this whole thing. Do we still take ivermectin? Do we still take all those supplements? Do we still check our diet and stuff like that?
Yeah, so the long haul one, I think I probably took the ivermectin for about 2 weeks straight when I had it. I stopped taking the ivermectin when I started feeling really better. The problem with the long haul one is the energy and the appetite, basically, and that's where the other kind of cortisone called prednisone, that's the cornerstone there. So I would still use the supplements, the melatonin especially, the lipo-C with all the bioflavonoids, the zinc, the vitamin D, the vitamin A. I would still use all of those, the nucleotides to help repair tissue. And then I would use that prednisone tapered. I actually just used the prednisone for about 7 days, which is half of the time that they recommend. But I was well, so I didn't. The moment I started feeling better, I started tapering it, But I tapered it over in 3 phases. But you have to work with your doctor. Prednisone is easy to take. The Medrol is a very bitter pill to swallow. People don't like the taste of it. But the prednisone is a tiny little pill. You can take it easily.
Okay.
Harry, then I'm going to ask a question that I've been thinking the whole time and felt too stupid to ask, but now I'm asking it. When do you start counting the days? From the day that you've been diagnosed, tested positively, or when you think that you've been exposed? How do you count your days?
You started counting when I say day 6 or day 7, then you start counting from the day you started feeling sick.
Okay.
And it's usually quite a distinct day. I mean, you like in my case, I had a little bit of, I don't know, maybe I had a little bit of feeling in my chest for a day or 2, and then that one evening, middle of the night, I just knew I had something. You know you have it. Yeah, and that's day 1.
No doubt about that. You know that you've got it. Yeah. That is no 2 ways about that.
Yes.
So I know there's still a lot of questions that people want to ask. People want to get into the whole vaccination thing, but we're not going to touch on that because that is a complete can of worms that we can open at another stage, because that will take 2 hours. If there's anyone who still wants to add a question, you can pop it into the chat box quickly. Dr. Lindeque, if they want to consult you, they can grab your telephone number from your website. It is there.
Sure.
And then see if you could get space in that busy clinic. I've been there last week. It's hectic when it's there. Supplements also from there, between oils, between Dr. Lindeque and myself, as well as some of the other oil people on the call. Please contact those people, because quality here if there's one thing that I've learned from Dr. Lindeque, it is quality trumps everything. So don't think you can go and get a second degree something and try and figure it out. If it's quality, it's quality. And especially in a time when we are where we are now, let's check our quality. And so anything from your side, Heinrich?
This was very good. Thank you, Harry. This was really good. And we've got every Monday, Eli and myself have this team discussion on health and wellness and all sorts of things, sometimes philosophy. So if you want to join, just contact us. But Harry, thank you. We really appreciate you. We appreciate the work that you do, the hundreds of people going through the clinic on a regular basis. We appreciate you and what the staff speak. And enjoy the evening.
Yeah.
Thank you. It's great to be with you guys. Thanks a lot.
Thank you very, very much. And we'll see you soon. Thank you very much, everyone. We've recorded this. If anyone wants it, please get a hold of us and we'll pass it on. Thank you.
Thank you, everybody. Bye-bye. Bye-bye, everyone.